So esophageal adenocarcinoma has a pretty poor prognosis. The large majority of patients die of their disease, even if they are diagnosed with localized disease at the time of their initial diagnosis. The current standard of care for patients with a localized cancer of either the esophagus or the gastroesophageal junction is chemotherapy with carboplatin, paclitaxel, and radiation therapy, then followed by surgery. And if they have residual disease present at the time of their surgical resection, they then go on to receive adjuvant nivolumab. So that's actually been an advance that we've had in the last couple of years, which has resulted in improvements in this disease. But overall, in the neoadjuvant setting, despite many trials being done over the years looking at several different approaches, we have never really been able to crack the pathologic complete response rate of around 25 to 30%, despite sort of trying to include novel agents, additional chemotherapy, and the pathologic complete response rate historically has been something that's sort of a predictor of how patients do over time. So we've really been for a long time trying to find a way to improve the pathologic complete response rate in these patients, which generally needs to involve a chemoradiation approach. Immune checkpoint inhibitor therapy is something that fortunately has shown to be of benefit in patients with esophageal and GE junctional adenocarcinoma in the metastatic setting. So sort of the next obvious question was whether or not there was a role for adding an immune checkpoint inhibitor in the neoadjuvant space. There has been some hypothesis that the presence of radiation as part of a treatment strategy helps to make a tumor more immunogenic, so perhaps adding immunotherapy in that setting would result in improved outcomes.